Starting medical school, she practiced as a genetic counselor in adult and child neurology, biochemical genetics, and medical genetics. She returned to her medical training here at Indiana University, and she completed a neurodevelopmental disabilities fellowship. But I'm going to tell you the real story. So I worked with this genetic counselor, and she was absolutely wonderful in neurology. And we could always call on her and count on her to be helpful to us as we saw patients. But one day she came to my office and she sat down and said, I want to do what you do. I said, well, you're going to have to go to medical school. And she said, I know. So she went to medical school, and 4 years later, she came back and she sat in my office and she said, I still want to do what you do. And I said, well, you're going to have to do a neurodevelopmental pediatric residency. That's 6 years. She said, okay. And she did. And we're so pleased that when she finished her residency, she joined the section of developmental pediatrics and then became our director of developmental pediatrics. So we're very pleased to have her here today. Her current clinical activities include neurodevelopmental pediatrics, Down syndrome, and neurogenetics. Her primary interests are the diagnosis and management of genetic neurodevelopmental orders and feeding, and she's very active in our Down syndrome program. So the development of healthcare clinical guidance for Down syndrome is really an arduous process. And it is one that consumes a lot of energy and a lot of input from the American Academy of Pediatrics. As many of you know, it is published by the American Academy of Pediatrics, and it goes through every section that is involved that has any input into Down syndrome, everything from ENT to pulmonary to cardiology. You can well imagine there are many. And so what Dr. Christensen, I'm going to turn this over to her now, and she will talk about what's new and what was recently published in the most recent version of the health guidance for children with Down syndrome. Dr. Christensen.
Thank you, Dr. Bull. Little nervous, very, very big shoes to fill, and I will do my best. So I am passionate about caring for children who have developmental conditions in the best way we can. And I see mostly kids with rare and ultra rare genetic conditions where we just don't know. And so I found this process of working with Dr. Bull and my other co-authors very interesting on how do we gather evidence, how do we evaluate it, and then how do we make recommendations so that everyone knows best practices for care of kids. In this case, specifically with Down syndrome, but there's lots of other conditions out there as well. The reason for this is, Dr. Bull and I talk about this all the time. She's an expert, and I'm hopefully will become one someday. But we bounce ideas off of each other all the time. This is written for folks who don't have that, who are out there on their own sometimes and don't see very many kids with Down syndrome so that they can do the best job as possible. So I have no financial disclosures, and I'm not going to talk about anything that's unapproved. And what I would like for you guys to get out of this evening is to hear about our updated recommendations for how we care for kids with Down syndrome. And then also be aware of what I consider to be some good resources on how to find the lists. So you, if needed, you can help your doctors stay up to date on things that we recommend that be done. And when I'm talking about this with kids in clinic, I don't really care who gets this list of things done. I just want them to get done. That's what's most important. And if that means you come down to Riley, great. If it means you stay closer to home, great. We know that if we do these things, kids do better. And so let's make sure that they get done. So the guidelines that I memorized, this would have been very end of medical school for me, beginning of residency, were published in 2011. You see first author, main author, leader of the pack, Marilyn Bull. And this has been her baby for many, many years. And so come around 22, we actually start working on this, I think 17 or 18. I mean, right before COVID and then COVID and it got slowed down. But we finally managed to publish in 22. And so this time I was so appreciative that Dr. Bull decided to let others in on the process. So my hope is that I can do this for other conditions and keep this going for Down syndrome specifically. And so it was a team effort, again, spearheaded by Marilyn Bull. She did the bulk of the work. She did almost all of the meetings at the AAP. She is a force to be reckoned with. Anyway, we had lots of Zoom calls and phone calls and passing written papers around and basically came up with a consensus. And this was the final product that was finally published last spring. So the reason we wanted to update is that we've learned a lot about Down syndrome over the last 11 years. So table 1 from the 2011 paper is there. It's relatively small. And then we were able to update this with further research and better description in the medical literature to table 1 from the 22 paper. I don't mean for you guys to necessarily read this, but just notice that this is what we have learned about Down syndrome in 11 years. Now, just for review, I know I'm speaking to people who are well-versed, but Down syndrome happens in about 1 in 700 babies, which means there's about 6,000 babies born every year who have Down syndrome. And currently in the United States, I should say currently, about 10 years ago, there were over 250,000 people with Down syndrome living in the US. Now, one of the things that we needed to update in the guidelines was the prenatal screening for Down syndrome had changed vastly from early 2010s into late teens and into 22. There was a technique called cell-free DNA that was developed and had become widely available and is currently widely available. It is significantly more sensitive, which means it's much more likely to detect Down syndrome, and it's also much more specific, so it's right more often. And so this can be done on a maternal blood test, and it gives us a pretty good idea if a woman is carrying a baby with Down syndrome or not. Now, this is just a screening test. It is not a definite diagnosis. It often gets treated like that. And so I always have pause that we always have to definitely do a confirmatory test. Now, when that confirmatory test gets done can happen at lots of different times. But prenatally, the diagnosis is still made by either chorionic villus sampling or amniocentesis, but it doesn't have to be done at that time. Now, from my point of view, and from many OBs and maternal fetal medicine doctors, why should we look? And I think the primary reason is it helps us take care of mom and baby better. That's the reason. We want to think about, well, where should we deliver? So we've learned over the years that a significant number of babies with Down syndrome end up needing NICU care. So maybe we should plan for that. Maybe deliver in a place that's closer to a NICU if that's something that is important for you. Other things that we can look for early on is to be able to plan for is you can get fetal echo and try to figure out, does the baby have have a heart defect, or do we have duodenal atresia? So it's basically we get more information so we can make better plans so we can give best care. And I view this as mostly for a baby, but also for mom. And then, of course, families can start learning about Down syndrome and get connected to wonderful parent groups. I know that DSI offers the discussions with expectant families, and I think that is wonderful. I think talking to someone, if you want to and if you're ready to do that, can be really important. That said, whenever I'm talking to families about their experience, or when I was talking about this before, is you do what works for you. If you're ready, do it. If you're not, wait, that's okay. If you want the information, we can work on getting you some. If you don't, then we'll do the best we can. You decide what's best for you. And that's the genetic counselor in me. As I've gone through medical school, I am a little bit more forceful, especially if I know it changes management. But I think seeking information is a lot about timing and where are you in your journey and what is best for you at any given time. Now, if we're not making a diagnosis prenatally, we almost always make a diagnosis in the newborn period. And so we notice things about babies, the facial features, kind of the wide gap in the toes. You can see the single crease across the palms. Now, I will tell you, I went to grad school with a woman who had two single creases. So some people have this and some people don't, and some of those people have Down syndrome and other people don't. But it's a collection of findings that point us in that direction. Now, the next part I'm going to say came largely from families. Dr. Bull and I have heard story after story about how this went badly. People did not handle this well. They told me negative things that, this was a sad thing when it doesn't have to be. So delivering the news, I think one of the best parts of the updated guidelines is it has a list of best practices of how do we best do this. And so number one, when you walk in the room, and this is what we do to this day in clinic, first time we meet, congratulations, your baby is beautiful. How exciting for you. You want to lead with that, lead with the positive. Always refer to the baby by name instead of it, or there's a lot of things that when people get nervous, I think that's part of it. But I think also when people don't have experience working with folks with Down syndrome, it can be dehumanizing, and I think that's a major problem. And so we want to use the name. We want to have the child present if possible. And you want to talk to the family as soon as you suspect, because people are smart. They know if other people in the room are like, oh, whispering in the back and, oh, something's wrong, that generally doesn't go well. And so we want the medical folks to say, okay, I suspect this, have a paper now that they can quickly read, so then they can go to have that conversation as soon as they can. We suggest that there's a support person there. This is not news that you necessarily want to get on your own. And so having someone available, I think, is really, really helpful. And then, of course, we want to give the up-to-date and accurate information. What the outcomes of folks with Down syndrome are significantly different now than they were 50 years ago. And so or even 30 years ago. It really depends on when the medical person trained and what their experience is on what they know. And so it's really important to give up-to-date information. And then, of course, offer connection to supports, because I think that there's power in talking to other people and not feeling alone. It's, I think, really important to realize that other folks have gone through this and can support you if that is what you want. So follow up. If there has not been a karyotype done before, you have to get a karyotype, period, always. I'm a stickler about this. I want to see it. I want to have it in the chart. So possible chromosome results that cause Down syndrome. Number one, most likely, is that 47 chromosomes total. You have that free floating extra 21. That's what my picture shows here. But there are some other things that can happen occasionally, and one of those is called translocation. And that just means that extra copy of chromosome 21 is stuck on top of one of the other ones, usually 14, 21, or 22. But that can have implications for family planning for the future. But again, the genetic counselor in me will say, no one should ever tell you what to do. We need to present options and present ways to get information, and then you decide what's best. And the last one that happens most rarely is called mosaicism. And that's when some of the cells in the body have the extra 21 and some of them do not. That makes it harder for us to predict how folks will be affected. And we have to watch kids more closely to make those predictions, and it may take us a little bit longer. But the difference between the top two, there's no difference clinically. They are the same. It doesn't help us take care of the child any better. It just helps us determine family planning things. So the basics for everyone with Down syndrome, you got to have a primary care doctor. I'm not going to be it. You don't want me looking in your ears regularly and thinking about colds. So you have to have regular well visits. Also, I want all the kids to get their shots, including the yearly flu shot. So the standard schedule applies to folks with Down syndrome as well. And then cardiology, 40 to 50% of people with Down syndrome have a heart problem. And so we want to look for it. And so all babies should have an echocardiogram, even if there had been an echo done prenatally. We want to repeat that just to be sure. And then we follow up based on what cardiology says, based on what they see. And then we only need to retest if there are symptoms that point us in that direction. Blood cells, this one is new. So the heart recommendation is the same as it was 11 years ago. We changed the recommendation for obtaining blood counts from hemoglobin, just regular CBC, to a full complete blood count with differential. We want to get that within 3 days of life or the first few days. So what are we looking for? We're looking for something called transient abnormal myelopoiesis, or TAM. That's what I'm going to call it from here on out. This affects up to 10% of kids with Down syndrome, and it usually goes away by the time you're 3 months. If it doesn't, you really need to follow with hematology. The reason we look for it is there is a slightly increased chance of developing leukemia early in life if TAM was present at birth. The other thing that we see fairly regularly, or up to a third of kids with Down syndrome will have large red blood cells. It's not really a problem. We just like to know it's there because it may affect how we interpret tests on the next slide. And then if there are any blood cell anomalies, we want to repeat that testing. And if there's still a difference at past the age of 1 week, then you should go touch base with a hematologist. Now, at birth, we get that complete blood count with differential, and then we're going to want to do it every year from here on out. So this is a change that we're adding the differential part. We will see anemia a fair amount. Now, really, kids with Down syndrome have the same amount of anemia as other people. It's just harder for us to detect it sometimes in folks with Down syndrome without doing the blood test. And then we also are screening for leukemia, which lifetime risk is only about 1%. The real thing to talk about is if your child is having bruising, bleeding, other symptoms of leukemia, we should get that test early. Let's not wait for the 1-year mark. But that helps us talk about the counseling for that. And then I added this last piece because I just mentioned leukemia, is the only other cancer risk, the only solid tumor that has an increased chance is actually testicular cancer. And that is also something new that was added to this version of the guidance. And so what we're recommending is that testicles get examined at every visit and that a trusted adult is aware and can help at home if needed. Other blood cell differences, I talked about anemia already, but iron deficiency. Iron deficiency is actually more common in folks with Down syndrome than in other folks, and it can ruin your sleep. So I have added it to my list of sleep questions for every child that comes to see me, especially those with Down syndrome. But if you have iron deficiency or iron insufficiency, that can cause restless sleep, and if we supplement iron, the sleep often gets better. And so beyond that yearly CBC and differential, we are recommending that we get a ferritin and a C-reactive protein, or CRP, to look at the iron stores, or you just get a serum iron and a TIBC. We have to remember that the MCV, or the size of the red blood cells, are often larger in people with Down syndrome, where there tend to be small in iron deficiency. And so you can't always use the MCV value to judge whether someone with Down syndrome has iron deficiency. Now, thyroid problems, this is the same. I lobbied really hard and thought really hard about maybe switching this up, and maybe this will get changed next go around. but we're going to keep it the same for thyroid checking. Now, the reason we care is abnormal thyroid function impacts your growth. It can impact your development, and it can cause constipation and lots of issues. And so I would rather find it on a test and fix it as soon as we can than have someone suffer for a while. And so we check it in the newborn period. In Indiana, newborn screen is good enough. You don't need to get a separate TSH. That said, if you live in other states where they don't do a TSH-based test, you need to get the TSH. So we do it at birth, we do it at 6 months, we do it at 1 year, and then we do it every year after that. If that TSH is ever elevated, we want to look at antithyroid antibodies. If those antibodies are ever elevated, but the TSH stays below where we consider treatment level, we want to increase the TSH checks to every 6 months. So again, what are we looking for? Early on, we're looking for congenital hypothyroidism, which happens in 2 to 7%. But we're really mostly looking for thyroid disease by adulthood. 50% of people with Down syndrome will have a thyroid issue by the time they're an adult. And again, this is easily treatable, and we can help. Now we talk about feeding difficulties, and because this is also fairly common early on. So we want to think about safety of swallow, and there's other things that can contribute to feeding problems. So if the baby was premature, has more than expected low tone than we expect for folks with Down syndrome. If the feeding's slow, if we're choking, not gaining weight, having breathing problems, we really want to think about looking more closely at feeding, because we can often make a difference with that. And then nutrition and growth is different in folks with Down syndrome compared to other folks. And so early in life, we frequently see trouble gaining weight. And then starting in the toddler years, we often are gaining weight too fast. And it's really important that when kids are, their growth is being assessed, that we use the Down syndrome specific growth charts. Here's a lovely picture. You can download them yourselves. They're on the cdc.gov website. I encourage you to have one. You can track your child if you like, or you can take it to your doctor's office if they don't have it, because guess what? We don't have it in the computer, and that drives me nuts a little bit. So I think that it's interesting to compare the Down syndrome growth chart to what I call the computer charts, which are the CDC and WHO charts, because the growth trend is very similar between folks with Down syndrome and others. And so that can be reassuring, I think, to say, well, my child is growing, and you can see on the other charts, but the percentiles are often different. The things that I'm going to point out is that we do use the CDC BMI chart after the age of 10, but otherwise we use Down syndrome specific charts. I often bring up with families that folks with Down syndrome are just smaller than other kids their age. And so if anyone gives you a hard time saying your kid's not growing, let's look at the Down syndrome chart and see where we're at. Other things to pay attention to are breathing. Early in life, you can have this high-pitched squeaking sound or wheezing, and some babies do need a car seat study before they go home. And then over those first few months, we need to pay attention and look for things such as sleep apnea, and get that evaluated promptly if we're concerned. Now, throughout childhood, sleep apnea is possible, and actually a whole lifelong it's possible. And so we counsel families about what to look for. So it's heavy breathing, snoring. I ask almost everyone in my clinic, are you snoring? Not wanting to sleep on your back, sleeping or just unusual places, or in positions. It also, poor sleep can ruin your behavior. It can ruin your life. And so unexplained behavior issues, and then waking up all the time. So if we're having any of that, I want to get a sleep study. What we added to the management guidelines, though, is everyone should get a sleep study between the ages of 3 and 4. What we've noticed is that parent report and family report and doctor suspicion, not very good. And so Dr. Bull and I in clinic have had a number of kids where we get the sleep study, and guess what? They had severe sleep apnea, and no one had any idea. And so that's how this recommendation got added, because sleep apnea is treatable in kids and most people. Moving on to the GI tract, some issues are present right away and we pick them up very easily and early. Others can show up a little bit more slowly, such as Hirschsprung's disease, but usually are detected very early. And then constipation can kind of come up at any point. It's really, really, really common. My big three things in clinic is, how are you eating? How are you sleeping? How are you pooping? Everybody, every time. So in folks with Down syndrome, the constipation can be related to you're just not drinking enough, we're not eating enough fruits and vegetables, possibly, and it's the low tone. Your GI tract is a giant tube of muscles, and if you have low tone other places, you're going to be low tone there, and that just sets you up for constipation. And then hypothyroidism too can contribute and cause this. And we can help with it, which is one of the reasons I like to ask. Then there's celiac disease. So this one we don't screen for. We do not test unless you have symptoms. And so we like to make sure that everyone knows what the symptoms are. So it's going to be someone who is older than 1 and who eats gluten in their diet. Some folks don't, and that's okay. But you have to have gluten exposure to have celiac disease symptoms. So symptoms could be diarrhea, that really difficult to treat constipation, growing problems, pain, bleeding, behavior as well. And so if we're concerned about it, we're going to get 2 blood tests, the TTG and an IgA. And if that's unusual, I'm going to send you to the GI folks because I need help. And they will do definitive testing to see if the person has celiac disease or not. Hearing and vision are really, really important. The reason I care is that hearing loss and vision problems impact your development. And if we can help that, we should. So hearing specifically is really important for speech development. And for kids with Down syndrome, 50 to 70% will have fluid in their ears at some point, and that's going to limit their hearing. And so we should look. This screening recommendation did not change from the 2011 paper. So we want to do newborn screening. If you fail, we follow that up. And if you didn't, we're going to retest your hearing at 6 months, 1 year, and every 6 months, like clockwork, every 6 months, no matter what ENT or audiology or anyone says, every 6 months, until we can test each year by itself. Once we can do that, and what age that is depends kid by kid, we can go to once a year hearing testing. Vision, immediately we want to look for cataracts, and then we want to get kids into ophthalmology before the age of 1 to look at eye alignment. Tear duct clogging is really common. Some folks have refractive errors or need glasses, and then there's slightly increased risk, but small chances of having glaucoma and things like nystagmus, which is eye jiggling. And those are things that we need help from the eye doctors. Now, this is new. So there's a technique called photo screening that is becoming more available in primary care doctors' offices. And so if the primary care has a photo screening machine and they can use that on kids with Down syndrome, if that's normal, you don't need to go see the ophthalmologist. If that screen is abnormal, then we need to go see the eye doctors, or if it's just not available, we also recommend yearly ophthalmology in the 1 to 5-year-old group, and then every other year ophthalmology in the 5 to 12. And then after that, it's based on vision concerns and screening that's done well child, and then previous history of eye problems. Atlantoaxial instability is next. This is not different. One of my favorite stories from Dr. Bull is I believe she wants this on her headstone, that she got rid of this requirement. And I tell patients that. I love this story. So the chance of having atlantoaxial instability is only 1 to 2%. But if your top 2 vertebrae get out of place, that's going to pinch your spinal cord. And as a neurologist, I care about that a lot. And that needs to be treated promptly. And so instead of doing x-rays, we need to actually look at the kid. That's what's most important. And so having a good physical exam and a good history is much better than getting those x-rays. And so we took those off the screening. I should say Dr. Bull took those off in 2011. Is that correct? So if there are symptoms, then we get the x-ray. The other thing families need to be aware of is that children need to have proper positioning when they're having procedures, because excessive neck stretching can cause issues if there is axial instability. So this is our handout from clinic. And so this is what I talk about when I'm telling families what to look for. What do I care about? So if your child stops moving one side of their body, they stop using their hand as well as the other hand, they start dragging a leg or up on a toe, I need to hear about that. We need to think about why is that. So it's differences in walking, differences in hands and arms. Also bowel and bladder control. If you had it and you've lost it, that's a sign of a spinal cord problem. And so this is another reason to look. Head tilting, this can be a little bit tricky because a number of kids develop plagiocephaly, especially early in life. But if this develops later, it's more suggestive. And people with axial instability and head tilt really don't like it when you move their head. So neck pain is another possible symptom. New onset weakness, which, I talked about the leg dragging or stop moving your legs. And then just overall decreased activity. Any of those things happen and can't be explained really well by something else, we should look at the neck with an x-ray. Sports participation, I think, is really important because one, it's social, it keeps you active, but let's not go hit our heads against other people or things. And especially we don't want to do things that increase risk for a spinal cord injury. So I don't like contact sports for this reason, but I also don't like it for concussion reasons when I'm wearing my other hat. Trampolines are a bad idea for all children. Unless they're like structured training program with lots of supervision, the chance is too high that you're just going to go flying through the air and land on your head. And then specifically for Special Olympics, you only need a physical exam. You don't need x-rays. And this still comes up from time to time where we get questions, well, for hippotherapy or for XYZ activity, they want an x-ray. And we're like, no, no, no. That is not necessary. It just makes you and them feel better. It doesn't do anything to help the child or rule out anything. Next up is behavior concerns. And this is new guidance that was added. So there's lots of common issues that we can see in folks with Down syndrome. ADHD is more prevalent, anxiety, some obsessive compulsive behaviors. Folks with Down syndrome, especially the younger kids, have a higher chance of things like wandering and just not doing what other people want them to do. Other things that are at increased chances are autism, which I'm going to talk about a little bit more detail, and then also a more newly recognized condition that's called Down syndrome regression disorder, which is still fairly rare, but we want people to be aware of it. I like to remind folks that behavior is communication. And so there is always a reason whether we can figure it out or not. And sometimes it takes a lot of digging and observing and looking and talking to other people to figure out what that is. And then it's also important to think about, where is the child developmentally, like where's their brain functioning versus what age are they? And we want to tailor any behavior approach to how they're thinking and acting, not necessarily how old they are, because that mismatch can lead to frustration from everybody. Now, I mentioned Down syndrome and autism. There is increased chance of autism in folks with Down syndrome. Looking through this literature, there's a wide range. And so we settled on a most agreed percentage of somewhere 10-15% or 7 to 19%. Now, general population numbers were just released last week or the week before. So general population chance of autism is now close to 3%. Which is still significantly lower than the 7 to 19% in folks with Down syndrome. And so symptoms can be present like they would in everybody else as early as the age of 2 to 3. And we really should use standard screening tools, such as the MCHAT in folks with Down syndrome at typical ages at 18 months, especially. That said, I have to acknowledge that none of these screening tools have been validated in folks with Down syndrome. The work just hasn't been done yet. And so this is what we do because it's what we have. I think it's really important for families to be aware and for other folks working with people with Down syndrome is to not just say, well, it's just the Down syndrome. It's just the speech delay. It's these other behaviors that can happen. If we're worried about autism, we're worried about that social interaction, we really need to do formal testing and then get help if that is the issue. Some interesting things have been reported about folks with both Down syndrome and autism is if you compare that patient population to folks with autism without Down syndrome, the folks with Down syndrome tend to be a little bit better at some of these imaginative play and social skills, but also are definitely lower or have more difficulty than same age peers and then other folks with Down syndrome. I think we all know that, the stereotype especially is that folks with Down syndrome are really happy and, friendly. And if that is not the case, we need to think about this. It's also important to get appropriate evaluation. And so you want someone who knows what they're doing, ideally, in doing an autism assessment, and then start intervention, which typically means ABA therapy as soon as possible. The other new condition that was added to the management guidelines is acute regression in Down syndrome. This goes by multiple names in the medical literature, so it can be called catatonia and then disintegrative disorder. While it can happen in late childhood, usually it's going to manifest itself in adolescence or early adulthood. And so things that we notice are regression, loss of skills, significant changes in mood, and then often some unusual movements that are not necessarily controlled. And also there can be repetitive thoughts as well. And this has to rise to the level where it interferes with your life. And this can be a somewhat challenging diagnosis to make. And there are a limited number of specialists who are familiar and can do treatment, but it's important to, if people are losing skills, we have to think about why. Now, we always want to go through the list of medical things that can do that too, like hypothyroidism and celiac disease and constipation and sleep apnea, and a long list of things to work your way through. And if we don't have those things, this has to be considered, mainly because there is very specific treatment for this condition. Now, other areas which did not change, I put neurology on there because that's one of my favorites. There is a slightly increased risk of developing seizures at early in life. It can be infantile spasms, and then later it's kind of what I consider run-of-the-mill seizures or epilepsy. We manage this like we would in anybody else. Skin issues are also more common. Dry skin, really, really, really common, such as eczema. And then there can be other skin issues as well. But we're going to deal with that the same as we would in anybody else. Teeth, I like to mention this usually around the age of 1 to 18 months, that sometimes they're different, and that's okay. I think it's good to have a warning, and especially as you're establishing care with a dentist to bring this up as well. So let's talk about early intervention. So this is really, really, really important, and we bring it up every time we see, especially this age group in clinic. So this is what covers kids from birth until 3. And the plan that gets put together is called an Individual Family Service Plan, or an IFSP. And what I think is beautiful about this program is the therapists come to the kid, wherever the child is, and I think it's delightful. Really, though, it's parents and family and caregivers who are the therapists. And so what I like to ask is, what homework did you get? What are you working on? It's the stuff that you do every day that you incorporate into your schedule, into your routine. That's what really makes the difference. And so I want to know what type of therapy you're getting, how much are you getting, and again, the homework. Because these early things, those are what actually I think make the biggest difference. As you age out of early intervention, we move into the public school system. And so they cover age 3 through 22. Yes, I'm hoping everyone knows that you can stay in high school through the age of 22. But things that I talk about with families, and I think it's important to be aware of is, are we in the right classroom setting? Are we in the least restrictive environment? That is a school education term. And those are important words to know when you're talking to schools. And so ideally, folks with Down syndrome are with other role models and around other kids of all abilities. And I think it's great to be exposed for everybody to see everybody else. So again, we want to think about, are the education goals, are they appropriate? Are they working on things that are hard enough, but not too hard? Do we have school-based therapies? How much is that? If we don't think that's enough, do we need to get you into private therapies to make up the difference? We need to look at transportation. How are you getting from your home to school and other places for school? And is that safe? I'll defer to Dr. Bull to discuss that further. We need to look at nutrition requirements. If this child has a G-tube or needs a thickened liquid or is not supposed to be eating lots and lots of snacks, like how is the school addressing that? What is written down into the IEP? And then of course, we just want to make sure that the program that is built by the family, and as the child gets older, usually preteens, that they're involved into this program as well as the school, that it's meeting each person's needs and goals. Now, transitions. I don't know, I think we could do a slightly better job on this, which is also, and I think lots of primary care folks can do a better job on this. But transitions, that's what pediatrics is. Kids grow and they change over time. That's what makes it fun, at least for me. And so we want to think about transitions early. And I know we all think about that big one. Well, we're going to go from pediatric care to adult care, but there's lots of little things in the meantime. So let's get started in early intervention. What therapies are we going to get? When we turn 3, what are we going to do next? Do we need private therapies? Are we going to go to school? How many days a week are we going to go to school? What kind of classroom are we going to be in? If we end up with a diagnosis of autism, are we going to do ABA therapy and school? Are we just going to do school? Or there's lots of things where basically times where things change naturally. And so I think that early conversations can set the stage for some of the ones that happen later. And so we want to think about, as we're going from kindergarten into grade school, definitely into middle school and high school, like what is the vocational plan? What do you want to do with your life? What do you enjoy doing? How are you getting along with other people? Do you have friends outside of school? Do you have social activities outside of school? Are you interested in other people romantically? Do we have, all people have these thoughts and feelings. And so I think having those conversations, setting the stage for answering the questions when they come in a developmentally appropriate way, I think empowers families and empowers kids and sets you up for success. We also need to think about long-term education. More and more folks with Down syndrome are going to community college, doing college activities. And so what's available? What do you want to do? What's best for you? And when I say you, I mean the person with Down syndrome, not necessarily the family at that point. We need to think about guardianship. Is that necessary? What does that look like? Who gets to make what decisions about finances, about healthcare? Like, how is this done jointly? And I think that can be different individual to individual. And then, of course, also thinking about long-term financial planning, especially for those who are going to need, and this is most everyone with Down syndrome is going to need long-term support. How do we set them up for success, but also family? And that usually involves financial planners and lawyers and things that I don't fully understand. I just know we need to do it. All right, summary. All right, this is what's new. We updated the prenatal screening because a lot had changed in over 10 years. Also, a significant, really wanted to add more information, more supportive information, more positive information for that early discussion of when folks screen positive for Down syndrome. And then once baby is born, if the diagnosis was made or not, how do we handle that first interaction? Because I think from learned experience from many, many people, it can be better. And so our hope with this document is that we can empower people to do a better job. We want to get CBCs with differentials in the newborn period and then annually because of the slightly increased chance for different hematology problems. And then, of course, we want to follow that TAM very closely if it is present. We want to look for iron deficiency, especially if there's sleep problems, but we want to look for that yearly. And there's two ways to do it. You can get a ferritin and a CRP, or you get a serum iron and a TIBC annually. And then, of course, there's increased risk of solid tumor chances and how to monitor for that. Thyroid screening changed in that we added the antibody checking, but the timing of the thyroid screen stayed the same. If the antibodies are elevated, people need to be monitored more closely. While the Down syndrome specific growth charts, I believe, came out in 2015, they finally were added to the guidelines here. And so more widely available, and we want people to use them as appropriate. Everyone should get a sleep study between the ages of 3 and 4. You can use photo screening if it's available instead of an ophthalmologist, and then only refer for concerns. Think about autism. It's more common, and we can test for this and get appropriate treatment. And so need to just think about it a bit more. And then really focus on those transitions early on to start, but also moving into teenage years and early adulthood. And really focus on shared decision making. I think I try to make that my model for most of the medical care I do. I'm like, okay, let's talk about options. What works best for you? This is what I think we should do, but how's that going to work? Or I think we should do these therapies. Can you actually get there? If you can't, can I help figure out how we can make that happen? And so I think a lot of this, it really does need to be shared decision making early on with the medical team and the family. And then as the child gets older, absolutely including them as well. So this is the single piece of paper, condensed all of the guidelines onto one paper. Doctors and other folks can use this. You can get it too. It's online. And I think it's a nice thing to have. That said, what I actually think is more useful is the healthychildren.org handouts. This is what we use in clinic. I go pluck this off the wall for the given age of my patient and hand it in, walk in there, and I go through the list with most patients every time they come see me, just to make sure that we're staying up to date on the guidelines. And these are organized by prenatal, birth, 0 to 1 month, and then it's I think 1 month to 1 year, 1 to 5, 5 to 12, and 12 to 21. And I want to say thank you. Thank you for listening to me. I primarily want to thank my patients and their families because I learn from them every day. And that's partly why I do this. I think it's fun and it's interesting and it keeps me on my toes. I want to thank the Riley Down syndrome team. Embraced me as a resident and medical student. And it's just a really good group of people to work with. I want to thank the co-authors of the team that put this paper together. Labor of love that took way too long, and we got through it in a pandemic. And then, of course, I want to thank Marilyn Bull, who someday I would like to be. All right. And I will take any questions that you guys have. All right, who has the mic? Okay. Oh, we'll get a microphone, or you can yell at me if you like, and we'll see if I can hear you. They can be done, I think, early as 9 to 10 weeks. I forget the upper age gestational limit, but they can be done first trimester for sure. Yes.
Down syndrome charts because they allowed maybe too much obesity. You're now recommending that we use them regularly?
Yes.
They've been updated?
Yes.
Okay, also,
The BMI chart, after the age of 10, you need to use CDC. Otherwise, they're appropriate now.
okay. Okay. Also with the atlantoaxial, I understand a neutral X-ray would make sense.
Yes.
How good is that at picking up a problem? And if it's normal and you still have concerns, you still refer?
I would, absolutely. Yeah.
Is it pretty good at picking things up?
It is after the age of 4. It's challenging in the littler kids, of course. We tend to move on to either CT or MRI if we have significant concerns in the younger folks, or if there's a negative X-ray in conjunction with we use neurosurgery around here, but orthopedic surgery in other places could do this. You want to consult the surgeon, and usually it's advanced imaging. Good. Well,
Thank you,
Thank
Dr.
you.
Christensen.
Thank you so much.
Just a half a word maybe about the atlantoaxial more. I just think it's so important that parents recognize the potential initiating symptoms. And I can share with you that I haven't, it's rare, and I haven't had many, but I've had a couple, and they were both one was brought about by a preschool teacher who noticed that the child couldn't use scissors because she was weak from the C-spine weakness. And the other was a mom who actually called us and said, you know, he is a little 7-year-old, and he said, he's hobbling when he walks. Well, what did hobbling when he walk meant? And they actually had gone to an urgent care who, guess what, did an X-ray from the waist down because it was a walking problem. And of course, it was totally normal. So it's really important to get the right X-ray and have people tuned in. So we want parents to recognize those symptoms that Dr. Christensen so nicely outlined. Any questions on the chat? There are? Great. There weren't? Oh, I thought you nodded yes. Okay, so thank you all so much for coming, but I have one more duty tonight, and that is to present Dr. Christensen for all her efforts. And she was an amazing part of that team that put that together. It really was it's a team effort. And we appreciate her being the Kelly Schreiner lectureship person this year. And we want to present her with a memento of this occasion that provides her the Celanie Christensen, MSMD, invited lecturer. So thank you very, very much.
Thank you. That's delightful.
So Celanie and I will be here for a while. If you have any other specific things or want to corner us for anything, we'd be happy to, I speak for her. I think we're happy to engage questions. And thank you to the Schreiner professorship, lectureship as well. This is what makes this all possible. So we really appreciate the Riley Children's Foundation and the Down Syndrome Indiana for their contributions today.
Very nice.
And that's Kelly's artwork, by the
Oh.
way, so you have to know that.
Lovely. Like that. Yes, you can go.
There might be more pizza out there.